You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to this special midweek episode where I chat with licensed psychologists Dr. Michele Bechor and Dr. Ciana Mickolus of the Neurobehavioral Institute in Florida, or NBI for short. In it, we discuss their stories, a team approach to OCD treatment, what it's like working in a big multidisciplinary team, the benefits for clients and for staff, a day in the life at NBI, and much more. And these midweek special episodes, which go out at the end of the month on a Wednesday, are made possible by and in partnership with the Neurobehavioral Institute in Florida, or NBI for short. I will be interviewing different members of their clinical team on a range of topics. NBI specialise in treatment and programs for anxiety, OCD, comorbidities, and complex cases. They also offer an intensive outpatient program and a residential program called the NBI Ranch, a supportive living experience that complements intensive treatment for anxiety and obsessive-compulsive related disorders. To find out more about their intensive outpatient services or the NBI Ranch, as well as to read some of their free information online about OCD via their blog, visit nbiwestern.com. So thank you to Michele and Ciana for their time. I deeply appreciate it, and it was really interesting to hear about this team approach at NBI. And of course, thank you to you guys, as always, for listening. And without further ado, here they are. Welcome to the podcast, Ciana and Michele.
Thank you so much.
Thanks for having us.
No worries. So, as you know, I like to get therapists' stories, so like why they got into being a therapist and in particular OCD. So whoever
you want to go first, Michele?
Yeah, sure. I'll start. So I had a tremendous interest in neuroscience even when I first started my undergrad years. And then as that progressed, I got into more biopsych and more about neuropsychology. And then in grad school, I worked on an attention-based protocol for anxiety in children. So I already started to get fascinated there with anxiety, especially the role of attention and anxiety. And then moving on to graduate school, finishing graduate school, I had a few OCD cases, and I was always fascinated with the anxiety aspects of it, and especially the impact on families and the role of parenting in that. So coming to NBI, we have a team approach, and we see, parents and families. And then my work in child anxiety translated really well to working on complex OCD. So just, again, between attention, then how compulsions work, and then just that you can impact, new patterns of behavior at a young age. And it has a lot of incredible downstream implications to adulthood was my passion just for working with children. And also just in that, the fact that they feel like they have to do something a certain way and it seems to have a story to them always fascinated me as well. So a lot of things kind of came together in being able to work with, parents, families, children, and just, OCD.
Wow, thank you. Ciana?
So my story is very different from Michele's. I sort of fell into the OCD world, and I'm very happy that I did. Before I started working with NBI, I was working with folks with eating disorders, which I think is very similar. So that was kind of the bridge to working with OCD, but I really didn't have a whole lot of training in school or after school in any of my internship or postdoc experiences. And I'm really passionate about it now. I think it's a really great fit for me clinically to treat OCD. But I think we'll get into that later.
Yeah, nice. And did you work with John Hoffman, Dr. John Hoffman, on the seeing OCD as an eating disorder?
Yes.
Okay, nice. Yeah. Did you listen to that episode?
Yes.
Yeah. Did it do it justice, the topic? Or?
Absolutely. I think so.
Okay, good. Asking for reassurance. Okay. So yeah, today we're going to talk about like a team approach to OCD treatment. So obviously NBI is a big center or clinic or whatever we want to call it. And obviously there's lots of you, and not just therapists, there's other skilled professionals there too. So I guess just very, very broadly initially, well, actually, let me start asking this. What's it like working at NBI? In this team?
No, that's a great question. you want me to start, Ciana?
Sure.
Okay. It's a very rich question. We could probably be here all day with us discussing the benefits and some of the pitfalls that come with the way that we do things because it's so complex and things like that. But just to kind of set the stage, you come to work and you have to work on a team. And I would say sometimes you're doing teamwork on steroids, just because you are trying to do what you learn to do on a one-on-one basis, but you are part of a team as a clinician with your patient. And each patient can have, 1 to maybe like 6 different therapists at work. And we treat really complex, really chronic cases, refractory cases in a day program, as well as in some cases, people from the community coming in to do intensive work. So just to work at NBI, you have to know what your role is on every team for multiple teams, and you have to communicate really clearly all the time, know what you're doing and also what you're not doing, and keep in mind things like ethics and risk and supervisory dynamics, and also know what your expertise is and your colleagues' expertise, and doing all of that with making sure you're keeping your patient's best interest in mind. And you can see it's like so rich already what I'm saying, and that's why we have so much to talk about, I think, with you today, because just coming in for one day, sometimes you come at the end of the day and you go, whoa, I did a lot today. And it's great. It keeps you really like on your toes and really interested for the next day.
Oh, good.
Yeah, so part of why I was drawn to NBI is the team approach. So that's what I was saying. I know we're going to talk about this. Most of the places where I worked before NBI was a team approach, and I never wanted to not have that in a job, because I think you can treat patients so much better, but also you learn so much more in a team approach. You always have someone you can go to who, like Michele was saying, has some kind of expertise in something that maybe you don't have, or you're the one who has the expertise in something and you can give consultation or supervision to someone else. And it's just so collegial, the environment that we're in, and people like coming to work and they like working together, and we're really passionate about treating patients and helping people. And I don't think you find that sure, you find that in other places, but definitely not in lower levels of care or an outpatient, because you're all by yourself in the outpatient world, which must be pretty lonely.
Yeah, it is. Yeah, I mean, I'm pretty much in that position, but how I've had to like build a system around it. It's not the same as being in the same building or lots of peer supervisions, supervisors, you name it. And that really helps. But yeah, it is important to have a team around you in some capacity. So yeah, I can absolutely see the benefits of having a proper team. So, and Michele, you said something about some clients have, or patients have, 6 therapists, up to 6 therapists. Yeah. I guess I'm just curious what context that is in.
Oh, wow. Okay. So why don't I also kind of like set the stage too about like when we're walking into work, what our patients are also walking into, because we interface throughout the day. So patients will walk in and they will have, in some cases, they're in this, the patients are in the clinic, 5 sessions in a day, 5 days a week. So they have really intensive cases, and we have cases where we get to customize care. In fact, we customize for every patient. So they can have once a week, all the way up to 25 a week, right? So just to give you an idea for them, the complexity that they have to experience as well, given the type of presentation they have and where they are in their journey. So we have individual sessions every day. We have many group sessions going on. Most patients will do like 3 groups a day. And then we also have nutrition. We have addiction recovery specialists. We have equine therapy right off site as well. And so in knowing that someone can have, let's say, 2 to 3 individual therapists, a parent therapist, a family therapist, right? Each person kind of covering a different aspect of the case and trying to problem solve from different angles. That's that we're on that team. And then the patients have to get this like curated, customized experience with all these different therapists. But it really also means that sometimes we have to think, hey, we're 6 people with different backgrounds and experiences, perspectives, levels of expertise, but we have to function like one person sometimes. And it's all in the interest of the patient, best interest of the patient. So it gets complex. There's a lot of talking around it. There's a lot of planning around it. There's a lot of training that has to go into it by far, because people coming in that are new have to know, again, what to do, what not to do, when to rely on someone if it's not for you in that moment. So again, it's tough for the patients, I think, to adjust to, and especially the sharing of information across the team dynamic too. And then for us as well, it's really, really about trying to parse out the function of a behavior, and to kind of even analyze, if a patient is reacting to the team dynamic a certain way, does it invite us to think, how would this patient react to something similar outside the clinic too? So it's really, really rich. Just takes quite a while to kind of get into and get the shtick of it.
Yeah. So in those teams is the equine therapist that's with the horse communicating to you straight away, or waiting for a team meeting to say they had a real big emotional response to the horse today, like stuff like that?
Most of the time we get feedback probably the same day, because we also have some residential counselors, meaning some trained personnel who go with the patients to the equine barn. So they might come back and they might share, most of the time same day, just the reaction that the patient had while there, because that's a really, really rich experience and gives a lot of fodder for behaviors, for reactions. There was even a time we had a mom go with her teenager to the barn, and even her reaction was kind of telling about how she responds to things.
Yeah. Yeah. Wow. And will you guys use that with the client? So like, oh, Dave and the horse told me, not the horse, but told me you really connected on something, or it helped you, whatever it is. Are you almost allowed to bring that up? Is there agreement with the client that you can spill over between sessions, if that makes sense?
A big, mostly yes. It's rarely ever a no. We have to use discretion, and we have to really use a lot of peer consultation throughout the day. And that's a lot of what we do too, is this sort of like unplanned, on-site as needed, let me grab you for 5 minutes kind of peer consultation, depending on the situation. But more often than not, we are making it clear to our patients that it's usually in the best interest of the patient that we do share information. We'll get a lot of patients that are trying to figure out where they can get more information about who knows exactly what and why, because that's part of just their own, call it anxiety, call it avoidance, call it attempts to control. And that's just what they want to do, and it's not necessarily bad. But really, we try to figure out what the function of that behavior is. So the overall answer is, yeah, we will share what we think is really important to share for the sake of, reducing behaviors we don't want to see or increasing behaviors we do want to see. So we make it clear, and it's tough, and it's an ongoing collaboration with the patient when we say, just so you know, I think I'm going to have to share this with the team, or I heard from the team that XYZ.
Yeah, that makes sense. And Ciana, anything to add to that bit?
Yeah, I was going to say that's part of why working in a team is so excellent, and having this level of care. So if something happens, let's say in an equine assisted therapy session, or in a family session or paired session, even a group, that will get relayed to an individual clinician that the patient might see later in that day. And then they can talk about what happened. Why was that so difficult for you? Let's plan for next time so that it happens the same day or the next day, and we don't have to wait a whole week or days to address something that for them was really, really meaningful and impactful. And we might miss the moment if we had to wait.
Yeah, good point. In terms of, you've already reeled off some various professionals, including like a nutritionist, or do you have anyone that does yoga there, out of curiosity?
We did for a long time. Okay. It's currently, I don't think, ongoing, but we had a yogi come in once a week.
Okay, cool. Nice. Yeah. Because obviously you guys are a therapists or psychologists. Yeah, but therapists still. Yeah. How do you work with people that aren't, quote unquote, the same as you in terms of therapists? I know the simple answer is you adjust, but like, what's it like talking therapeutically with a nutritionist or with some other professional? And equally them talking to you in nutritional terms when you're not nutritionists.
I think we meet all the time. And so we're all really on the same page about things. So at least in our practice, there's not a whole lot of extra education that we have to do because we're all on the same page.
I was going to say pretty much the same thing. I was going to say what's really interesting, you actually learn by default, and having worked in our clinic, really the way that we're built, that it doesn't matter too much what background you have if you all decide that there are certain behaviors that have to decrease or increase. Now, we all, every single one of us, are extremely devoted to this professional value of evidence-based practice. So that to me is a fundamental, not only reason why I love where I work and a thing that drew me to NBI, but also just that if the nutritionist also is going, okay, we have to do evidence-based work and we believe in each other's work, we all have an agreement on how we would like to see this patient function. So we just go, okay, you're going to use your expertise, I'm going to use mine. Let's actually inform each other if we absolutely need to. It's funny, our nutritionists know how to do exposure. They don't do it, but they know how to do exposure because they'll often see us do it live. Or we've had groups where a nutritionist and a clinical psychologist would sit together and run together because we will overlap. We will find that common interest. And so, yes, you learn, but really, again, more importantly, you learn that if you both have the same goal, the backgrounds aren't as important. They're not going to divide you.
True, that's a good point. You're all around OCD all the time, so the nutritionists are going to know it inside out as well. This isn't some random nutritionist. This is someone that works at NBI that sees it all day, every day. Yeah. Okay. Nice. So let's get into maybe some specifics of it. So obviously, some of the things you brought to me beforehand were like parent training, family therapy, group sessions, individual sessions, substance counseling. Like, how does this all intertwine, and how do you work with these various professionals? So maybe you're working on ERP for OCD, but they're also seeing a nutritionist, maybe a family therapist, maybe you've got to meet with parents as well, substance counseling. There's a ton of stuff going on there, and obviously not every client is going to need all of that, but how do you almost like manage all of that? How does that fit into their day? How do you fit into their day? Like, I'm not quite sure what I'm asking here. I guess maybe just trying to picture it more in my mind.
I think like saying what stitches it together, right? Like, how do we do this, right? I know in a previous podcast, John and Katya talked about like how the sausage is made, and that we have to spend a lot of time planning how we talk, and then we have to actually communicate. And so for us, we're meeting every day. We have different interfaces. One, especially where we're kind of giving live updates throughout the day about how patients doing, especially the date patients. So we have live meetings. We plan which patients we're going to talk about that day, and we try to allocate time so we get through as many patients as we can. We actually have to decide together too which patient might have the higher risk or the highest risk, and go, okay, who needs to be spoken about first based on need right there. And then again, if it takes texting, if it takes carrier pigeon, doesn't matter, where you have to actually get that message to our colleagues, even after hours sometimes, just to be able to coordinate. And I say pass the baton, and then also it comes to mind for me as a little bit of like hot potato, but you do not throw the hot potato. You say, hey, it's a hot potato, please. You have gloves, take it from me.
Yeah. And Ciana, anything to add to that?
I think that communication is really what, like you're saying, stitches us together. We are constantly in each other's offices, messaging each other, calling each other, having formal meetings to make sure that patient care is moving along the way that it should be moving along. And if we're ever stuck on a case, we're talking about that immediately and planning an intervention so that, like I said, there's no lag time. And that's really the benefit of having all of this treatment all in the same place, all your providers all in the same place, is you don't have to wait if there's a problem.
Yeah.
So if we're doing exposures that are too hard or too easy, we talk about it. If a patient is responding to me in some way and Michele in a different way, we're going to try to conceptualize why that's happening, and do we need to change, or do we need to have a conversation with the patient?
Interesting. Yeah, or is my personality style triggering something in them, and what's that about?
Exactly. And maybe is this a thing we want to continue to trigger, or is this a thing that at this moment maybe not?
Yeah. And to a degree, you have to almost like balance too, like what you've been trained to do with the dynamic that's at hand. So pretty common thing for us to hear from patients, especially over many years of doing it, is I want to change the roster of my clinicians. I like 4 clinicians, but not my 5th clinician. And we have to think very, very carefully about the function of this behavior, and or that this is a stimulus that the patient is responding to. So we go, okay, in context, is it in the patient's best interest? And or, if it's not, what are we going to do about it? Does it have to be just a conversation? Does it have to be a limit that we set? Does it have to be, a potential threat to collaboration with the patient? And we really hope it doesn't. Most of the time it's not, but it's a matter of having to be clear and continuing to analyze with your patient together, like why that change may not be strategic. And they don't always like it. And we can say, that's potentially an exposure for you. We also don't want to over pathologize either, because in the real world, we can change things too. So we actually need lots of perspectives to come in at one time to say, wait a minute, we're in an artificial environment to a degree. And then we also have a real life aspect to what we do to a degree. Hold on, which one's going to function the best for this patient?
Yeah. Good points. And, both what you're saying there makes, I guess the question comes to mind, and you may not know, but I'm sure you do based on feedback you guys would have got, is how is this multidisciplinary approach experienced by or received by the client? Like, is it seamless? Do they notice it's jolty? Do they, how do they like it? Do they not like it? Is it confusing? Is it comforting? And I'm sure it depends on the client, but just anything you can say on that.
Yeah, I think it depends on the patient, but for the most part, I think they like it because people in the real world too, people connect differently with different people and different styles, and people have different backgrounds. So maybe a patient will really connect with me about something and they'll feel comfortable sharing that something with me first. And then we can work on how they expand that to the rest of the team. Whereas if they only had one person, they might never share something really important because it just didn't feel right for them. And the clinician would never know.
True.
Yeah. And it depends heavily on the patient's background, because some patients come into our setting, let's say intensive outpatient or, that 25 sessions a week type therapy. It's their first time and they have to adjust, and they are severe and they're coming for help. And we have to be really, warm, compassionate, kind, really understanding that they're adjusting to something very complex. So we really try to relate to them on that. And that other than that, if they aren't used to that, if they also may also be used to it, they just don't like that style. Again, sometimes there are people, let's say one patient I can think of right now with OCD who really, really wants to make sure he's aware of who knows what, when, and why. Really, really just his own sort of sense of information and sharing is part of the OCD. So this is the disorder directly impacting how we're doing what we're doing. And then that really pushes us to analyze function and best outcome for the patient again.
Yeah. Wow. Yeah. I can imagine it gets tricky. And Ciana, what you were saying there about, let's say, for example, a client takes a shining to you and they maybe don't dislike the other therapist, but maybe don't feel completely at home, so to speak, completely safe enough to share their deepest, darkest secrets. Would you then advocate on their behalf and encourage them, I need to share this with the team, or can I do that? And then almost be their champion. And I guess that would happen for different people. Everyone would have their favorites. And do you guys sort of take a lead, I guess, is what I'm asking, within the team?
So part of that is it would depend on the patient if I'm going to share this information with the team or if I would encourage them to share it with the team. Yeah. Usually I want them to do it because it's an exposure.
Yeah.
And a skill.
and a skill. Yeah. So, yeah. And like you said, people take shinings to different people for different reasons, and we don't take it personally. That's okay. That's part of how it goes.
Yeah, true. Okay, good. Let me think. What else do I want to know? Yeah, I mean, you've kind of talked about frequency of meetings. What does like the average day in the life for you guys look like? Is the schedule set for you each week, or do you have to negotiate that? Like, how many times are you meeting? Obviously, you do the micro meetings as well, where you just grab 5 minutes. But yeah, I remember Katia and John maybe saying something like there's like 3 hours of meetings a day or something. Could be making that up, but something like that.
So at least I'll talk about my day and then you can talk about yours, Michelle. My day is comprised of patient care and meetings. So let's say in the morning, I run a couple groups. In the afternoon, I'll see patients. Pretty much every day at lunch, we have a staff meeting where we talk about cases. Outside of that, like before, there's micro meetings. So we'll pull someone in for this. Maybe we'll pull a team in for a brief team meeting. Maybe we'll have a meeting with the patient and the parents to talk about something, or maybe a team meeting with just the patients. Also, Michele and I supervise, so we'll have supervision in a day amid anything else that comes up. So we have to be flexible as well.
Yeah.
Yeah.
Is that similar?
Yes. Similar, sure. Yeah. So I might have, I have, a good mix of parent, family, and individual most of the time. And then I have groups as well. We have some groups that are really didactic and classroom-like, and then we have other ones that are a little bit more experiential, like exposure-based group, or even like process group, as long as we kind of keep it really skilled. And also we have like preset meetings where we know we're going to talk and in a very structured way. And then we have those impromptu meetings as well. Not to mention, we're trying to chat together on this interface most of the day too, just to kind of have updates and a record and everything. Then we do have report writing. We do have to have impromptu or planned calls. And a thing that to kind of bring in from the outside actually is we don't have a psychiatrist on our staff. So this One More Time actually houses stopping and thinking about what we would kind of want in an outside provider, especially when psychiatry is so important in the work that we do in psychology. So we often work with a psychiatrist that a patient may already have, or will recommend a psychiatrist. And for example, more recently, there was a patient that came in and did not have a psychiatrist. So I found myself trying to guide the patient on how we would work with this psychiatrist. I found myself saying, we would hope that this psychiatrist would share our view on evidence-based practice. And we would try to see if there's, again, in the best interest of the patient, as far as we understand with our orientation, if that's going to work for us. And then we have to bring in that psychiatrist for appropriate and timely communication as well. Not only that, we might talk to a general practitioner. We might talk to a family member, if not just in family therapy. We just bring in people on the outside as we need to coordinate care. And again, you're trying to think about the person's environment for when they're going to leave, especially intensive programs. So they're going to head out. They have to have a lifestyle that they're ready to go back into and not get back into those negative patterns that may not be working for them. So overall, you're coordinating with anyone kind of internally in a formal basis, sometimes informal, and then you have to balance information from outside the clinic as well.
Yeah. Wow. Okay. So a lot of balls or plates you're spinning. And I'm curious why NBI doesn't have a psychiatrist on staff, whether there's any rationale or whether it's just a financial decision, because I'm sure they're pricey. Yeah.
Well, I think that they all bring different strengths. And I think that it's possible if we had one on staff, there could be like a certain way of thinking that was maybe, we say, reified, meaning, oh, we'll do it the way we did before. And each case is really different. And there's, to a degree, a generalization aspect as well, because this psychiatrist is probably going to be with this patient even after NBI, so to a degree, there's an element of therapy that can carry from outside of us as well. I think there's times we've had them and times we haven't had them. So overall, we found that this model works best for us.
Yeah. Good point. Okay. And so you mentioned parents and parent meetings. What's that like? Is one of you guys meeting with the parents? Is the whole team meeting with the parents, or does it just adjust according to need?
Yeah. So mostly we have one parent therapist, and that's to another degree of having to delegate and having to divide and conquer and say, hey, there's a set of behaviors that we want to increase and decrease, and we want this person to go back into an environment and not slip back. And so we have to think, wait, what's in this person's environment, right? There are even sometimes, though, we have, adults who are in their 30s, and we still have to work with parents very actively because those parents are just in that person's life. So it's not always age-based. But to a degree that the parent can really, really influence the environment, which is tremendous, right? Especially in terms of, behavioral modeling live or reinforcing without knowing that you're reinforcing. I mean, it's tremendous to think about how much influence can actually be, provided via parent training and via parents changing their behavior, but also keeping in mind that your parent is not your patient, They're just people that are collateral to the case, and it's really kind of tricky. So there's usually one parent therapist who coordinates closely with the family therapist for obvious reasons, because often parent trainers are trying to help the parents function in family therapy. Let's say they have to get through a skill or learn some more education about a concept so that they function a little bit more effectively for the child. And then we will meet with parents sometimes as an entire group. There are just times where the entire team is available at one time to talk with the patient or the parents or them all together.
Okay, wow.
It's also important to have a separate clinician do parenting and do family, especially because of the concepts that we're talking about. So a lot of the time in parenting, we're talking about how to reduce accommodations. So in adult patients, that's very challenging to have a clinician talk to a parent about reducing accommodations and then also align with the patient, because the patient likely doesn't see it that way, especially in the beginning.
Yeah, good point. And are you guys liaising much with the family therapists and parent therapists? Obviously in the meetings and stuff, but because I can imagine stuff that goes on at home with accommodation that filters into the sessions with your client.
Yeah, for sure. So we are a treatment team that really emphasizes parenting and family. Like that's one that really like helps make NBI what it is in a lot of ways. And it's just been shown so many times in our cases that making sure that, let's say, parents or again loved ones that are close to the patient are really in the know and on board, and to a degree doing things really differently than how they're used to doing it. I mean, you're supposed to protect, right? You're supposed to accommodate, you're supposed to be loving. And we have to chat with parents and kind of change their own paradigm, because if you let your child have distress and learn how to self-regulate as long as they're safe, then you are loving your child. You're just sort of showing it in a different way. So you have to have discussions about limit setting and also what the effect of your child's distress is on you as a parent. So you have to have really frank discussions about whatever it takes for there to be more readiness for change, to then have parents decrease certain behaviors or increase certain behaviors. So then the children, or again, even the adult children, will get more in line with treatment, be able to have that support.
Yeah.
And with older adults who are married, I also want to talk to spouses.
Yes.
To see what's going on there, if there's any accommodation. And for those sessions, I frequently will have the spouse join me in one of my sessions so the patient can see what I'm saying and why I'm saying it. And it's a lot of psychoeducation at first for the spouse, or I'll have the patient discuss what OCD looks like, how the OCD cycle works, how their symptoms fit into the cycle, and how accommodations are also fitting into that. So then as a couple, they can move forward together, because OCD isn't just about the patient. It's about the whole system. It impacts everything that's going on in the home. So I think spouses are really important too.
Yeah, absolutely. I agree with that. Yeah. So we've obviously talked about it all the way through, but if we were to like bullet point it almost, what are the benefits to the patient of being within this team setting?
So I'd start out by building this bullet point list with, you have the chance to connect differently with a lot of different people. You also have many people with different expertise and perspectives considering what's going on for you. You also have their expertise at your disposal as well. Like if, let's say, your treatment journey has it so depression really increased in the last few weeks, and on your team you have someone who's particularly well-versed in depression treatment, then that person's on your team. No need to go get another person to add on to your team or shift anything around. So lots of perspectives, lots of people that are all intended for you to have a life that you really want.
Nice. And
something to add to this bullet point list is fast response time.
Yeah.
So because we're talking all the time, we're seeing what's happening in the milieu, we're seeing what's happening in individual sessions, that is getting communicated to other clinicians, and then we can address it then and there.
Yeah, really good point. And similar list, but this time benefits to you guys? So the professionals, like, you both seem happy there. Although you have to be, because Katya and John will watch this, won't they? So, no, I'm sure you are. So, what's the benefits to you guys of being in this setting?
I was going to see if I can jump in first on this in particular, because I wanted to plug one extra thing about my experience. I mean, I came out of grad school and I was a very green, very fresh postdoctoral resident. So my first 2 years out of graduate school, the first time doing applied psychology all the time, 40 hours a week plus, I did a lot of fantastic clinical work in my training, but then my clinical work, really grew really fast in those first 2 years. And I really do credit that growth to that I was in a group setting, because from my perspective, I could see all of my colleagues every day trying to solve the same problem that I was trying to solve. It's really tremendous, actually, because somebody could be 5 years, 20 years, 30 years, 40 years more advanced in the field, and we're looking at the same exact problem. And I also could hear them say, oh, well, for that component, I'm going to do this. And it was some kind of evidence-based practice that I knew about, but didn't really see in the flesh. And I could either shadow or learn about, or just even hear the pairing, right? Like just hear that therapist say that little intervention needs that. And all of a sudden my encyclopedia, my vocabulary grew tremendously, because what a great experience, specifically for trainees who can go, oh my gosh, people who've been doing this for so long are trying to do what I'm trying to do. Let me see how they're doing it, and kind of compare that. It was a great experience.
Amazing.
Yeah, I couldn't agree more. As a clinician, I have grown so much, and I've learned so much about the treatment of OCD and anxiety and related conditions. It's been incredible. John and Katya are so knowledgeable and so humble, and they're willing to share all of their knowledge with us, which is just amazing. So as a clinician for training, I think it's great. For professional development, I think it's great. As well as on a team, you're always doing something different. You're doing a little bit of parenting, a little bit of family, groups, individual, and we have the flexibility to do that. So some people who really excel doing groups, maybe they'll be doing more groups. Someone who really excels doing parenting, maybe we're going to have them do more parenting, as well as training to make sure they're a well-rounded clinician. So that's part of what I love, as well as now I get to train other people. So
that's great.
As a supervisor, it's really excellent. I get to give back to the field.
Agreed. And to add one more thing also, I was just, as a supervisor, just kind of informing my supervisee about how to manage risk in the clinic. And of course, I say pull in someone, but I don't have to just say pull in me only immediately. I say look for the next more trained person, usually licensed person. And that's, again, that whole quick response, right? If something's going on, it's not just for the clinician to get that relief, it's for the patient to really get that next skill that is needed. So that wide availability of people that can help is really great. And I think that actually goes both ways, right? Patients and clinicians alike.
Yeah, really good point. Yeah, that support system, just for the client, for you guys, most importantly, because if you're not contained, it's hard to contain the client. Okay, nice. So is there anything else you guys wanted to say on the team approach today?
Just to conclude, I guess I personally think this is the best way to treat patients, and I wouldn't have it any other way.
Yeah. I would say also in doing this, if ever you're going to consider aspects of it, then just continue, keep in mind that we're really as humble as we can be about it, meaning we've had patients give us feedback sometimes that they're kind of like uncomfortable with whatever dynamic, or they think we might be over pathologizing. Because think about it, several therapists are in one room at one time. You're going to get a lot of opinions. And so patients might get like a trickle down effect from that, but we have to take that feedback and we have to check in with our patients really frequently. I'm more than happy sometimes to sit with patients and say, how's this going for you? What do you like? What do you not like? And then we are editing a lot too. So you have to be really committed to trying to be dynamic and keep it that way. And it keeps you really fresh and humble yourself. So it's like, just remain really open to feedback. Just know that it's so customized and you're really just trying to get people to have lives that they want to have. Super hard, but you're trying your best. And just kind of like shift as you need to, really, as I would say, if you ever want to consider more of a team approach.
Yeah. Yeah, I like that. Really good points to end on. And last question then for you guys. You've both got a billboard somewhere in Florida. What do you want written on that billboard?
Whoa. I mean, I like the idea of like, have any experience. Like you could say experiential tolerance. And then when I have to have a lot to say before I say have any experience, I still like to say that, like, try to be open, try to be curious about anything that you're going to go through.
Yeah, absolutely.
I think my billboard would say something about enjoy the journey or enjoy the ride, because that's what life is about. It's what happens on the way to your goals.
Yeah, good point. Yeah, very true. So look, guys, thank you so much for coming on and talking about a team approach. It's definitely great to hear that this sort of thing exists and the benefits of it. Yeah, thank you so much.
Thanks for having us. It was a pleasure.
Yeah, thank you so much.
Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us with a one-time tip/donation, please go to theocdstories.com/support. All tips, no matter how large or small, are greatly appreciated. Please subscribe and rate the show wherever you listen to the podcast. So thank you to NBI for supporting our work, and if you would like to find out more about their intensive outpatient services or the ranch, head to nbiwestern.com or the link will be in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.